Hey everyone, good morning. Let me know if you can hear me. Going live. Good morning, everyone. Just let me know if you can hear me at all. Hey, Kitty. Joining me today? Hopefully. Good. We're gonna get started in here. I'm a little under the weather necessarily, but I'm having a pretty strong immune reaction to my second dose of the COVID vaccine. So if I seem a little out of sorts, it's probably because of that. So no fever, but a lot of aches and chills. Well, I guess that means it's or the tracking chip is causing a reaction. Could go away with time. Nothing a little Tylenol and I can't help. $14 people in bar. Everyone else shows up. I know it's early, but the traffic's not too bad. Oh, thank you. The tracking chip's really gonna help out a lot when also have my phone in my pocket constantly telling Google where I'm at all times, but yeah. But I'm not here to talk about conspiracy. We're talking about the truth. I have a couple of questions on the prescription assignments. I'm gonna answer some of those first because I know it's a little different than what you guys are used to. So walk through that a little bit. Of course, if you have any questions, feel free to post them up in the chat or sticky board, either one. Oh, yeah, not a lot of people use pictures in the sticky boards. That's kind of cool. You guys can utilize that. Right, it's 8 o'clock, so I'm going to get started here. All right, so as I mentioned, there's got some questions about the prescription assignment I wanted to address a little bit. So first off here, someone was saying regarding the prescription writing assignment, how do we structure our written orders for the homework when it does not match actual post-operative protocol? If the patient is getting analgesics for severe pain through IV, why are they getting PO pain meds as well? Do you want us to write for multiple IV drugs or just simplify it to one? So there's a lot of different pain protocols that are out there. Keep in mind, there's also going to be a lot of variation based off the type of surgery that's being done. So, for instance, laparoscopic cholecystectomy is going to be a lot less invasive and painful post-operatively than something like spinal fusion or something like that, right? So there's going to be variation, and so I just kind of picked a middle of the road sort of strategy that kind of utilize IV and PO meds. Also, if you look at the one here that was presented, they also talk a lot about like PCAs and epidurals and whatnot. I don't want to get into that right off the bat because that's a little bit more complicated. And so I wanted to keep it relatively simple for your first set of inpatient orders there. So And yeah, there is certainly reason to have both IV and PO meds available on your orders, because if you imagine someone who's still having severe pain, yeah, you want to give them something IV because that way it has pretty good bioavailability. That's going to help manage that pain there. But as they start to get better, as they start to recover, they may not need those IV meds anymore. And so if you can start to transition them over to oral meds, then you're going to find that by transitioning them over to that, that's that much quicker that you can get them off their IV and get them ready for discharge, right? If someone's still having IV meds being administered, they're not really ready for discharge yet. So the goal is to get them off of all the IV meds, onto PO stuff, hopefully off pain meds entirely before discharge. So that's why you'll see that more for like moderate or mild pain. You'll see oral alternatives, while IV may have IV, or severe pain will have IV options available. So it really just depends on the patient, depends on a lot of other factors there. So again, I wanted to pick a middle of the road sort of situation. So I would just go with that. So if it says do an IV drug for severe pain, that's what I'm looking for. If it says do an oral med, do an oral med. And again, I want you to get a feel for writing different types of orders for an inpatient setting. So how do you write IV meds versus PO meds and those things? So again, sort of multifactorial in terms of how I made my decision, but there was a method. Whether or not it accounts for the madness, I cannot necessarily tell you. Let's see. Someone says, for Voltaren, why does it have a little dosing table / measuring tape? Can you overdose on topical NSAIDs? Probably not in the traditional sense, but it allows you to get a consistent dose, right? So, and you see this too with like nitroglycerin, topical ointment, how you'll have like a little bit of a paper that has like a measurement on it. And the goal is not to like slather up the whole patient with Voltaren gel, but you may want to get at least a consistent dose. And so if they're just eyeballing it in terms of how much ointment they are dispensing to themselves, it may be not consistent. So by using some sort of measuring table or something like that, it can help to provide a little bit of consistency. So that's why I imagine they would do that. You probably see just a lot of local skin reactions more so than anything else, but you'll get some bioavailability from the transdermal administration, but it's not going to be a ton. So they'd really have to cover a large surface area for it to be a problem, I would imagine. Someone says, for the ARCS assignment, do we disregard the duration since we are only giving meds for a single day in inpatient setting? No, you don't know how long that patient's going to require treatment for, right? So like, for instance, they may, for that procedure that I picked, I see that those orders quite a bit for our patients. We have actually a surgeon who that's like what he specializes in, is doing those NUS procedures. And so we do probably see 2 or 3 a day when I'm working there. And so, you know, they may be 2 or 3 days inpatient while they're doing that. So unless it says to put a specific duration on there, don't put a duration. You can just let it run kind of continuously. So unless you say, you know, do this order for 3 doses or for 24 hours or whatever, it's just going to run ad infinitum until, you know, basically the heat death of the universe, unless you come in and then DC that order or modify it or something like that. So that's, yeah, so you don't have to put durations on there unless it's very specific, like the antibiotic order that I mentioned, okay? So there's that. Someone was saying, can children have PCA? It's a really good question. So we'll talk about PCAs briefly here, I believe. But in general, so it's patient-controlled analgesia, where basically you can have a cartridge setup that's infusing meds, and you can either be running at a continuous rate or no rate at all, and then if the patient needs a dose, they can hit the button for themselves. It obviously requires a patient to be at least with it enough in order to be able to press that button. You typically don't want family members doing the button presses for them because they may be, you know, more or less sort of generous with the medication. You know, if I thought my kid was in pain, well, yeah, I want them to get pain meds when the patient may not really need it, you know. So obviously if it's like a 3-year-old, probably not, right? But, you know, if you had like a 10-year-old, you could probably explain how to use the medication or how to use the button in order to get pain medication. But we'll probably mention that a little bit later on. A couple other questions someone had, so it's on I have a sticky note here for myself. So it said, the second prescription on the assignment indicates oral medication for mild pain. How are the patient's MPO? Do we write oral med or IV? So MPO is kind of a, it's not always super clear necessarily when you see MPO in terms of how MPO that really means. Generally speaking, it means no like food or drink by mouth, right? In general, you're going to find most of the time NPO does allow for oral meds to be given. You may see some specifics that says NPO including meds, And then that way you would not want to do anything oral. But typically an oral medication is going to be reasonable to administer even if the patient has a MPO from a diet standpoint. So you can still definitely do that. When writing for IV doses, do we convert to ml or is it grams appropriate? Your example maintains milligrams. For your purposes as a PA, just write for the milligram amount or whatever the actual dose amount is. Concentrations can vary amongst different institutions. That's more on the pharmacy side of things. So I would just go ahead and keep it simple and just do the dosages, and then people on the pharmacy side will figure out how many mLs that is to administer. The one exception for that would be for IV fluids, right? So you'd want to keep that in mLs per hour, or if you're doing a fluid bolus, how many mLs in total that patient should be receiving there. So there's that. Someone says, are we writing all prescriptions for 24 hours? No, unless I put a specific duration on there, just go ahead and keep them on there. Because remember, you're going back and seeing that patient day to day, and you'll be making those decisions. Do they need to continue that medication for severe pain, or can I DC that? Do they need to continue this medication for fluids, or are they having good PO intake and they're advancing their diet and I can DC that, right? That's why you don't put necessary durations on there, because if the medication order falls off and then no one catches it, then that patient may be going without pain meds or maybe going without fluids or whatever the case may be. So typically durations are not set in stone on those because you're going to go back and see the patient and modify it or DC it yourself, okay? And then the last question here was, I'm a bit uncertain about the last prescription for Ansef. Since a patient took one dose at 10 a.m., should we just subtract that dose from the prescription? EX, if Ansef is to be administered 3 times every 8 hours over 24 hours, should the prescription just indicate the 2 remaining doses? That's what I'm looking for, right? So you want to take into account when. So the reason why I do that one in particular, is because I want you to think about timing of things as well. It's not just a matter of just starting the order as soon as you write it down on paper, but timing of medications can be important, especially for antibiotics. So I want you to take into account when the patient got their first dose and then when they need to follow up and to start the next dose, right? So that's part of the process, and that's a constant thing I'm always having to call providers on. To quite frankly, I have to call them all the time to be like, hey, you said it to start this medication start right now, but they just got a dose 15 minutes ago. Can I modify this to start, 6 hours from now, 8 hours from now? They're generally okay with that. So I want you guys to think about that sort of stuff early, so that way when you're out there writing orders that you can think about it then as well, because that can lead to medication errors. You can't always account for the pharmacist to pick up on those sorts of things. It's that Swiss cheese model for medication errors, right? You want to be able to cover up as many of those holes because you never know if someone's going to be able to catch your errors or not, right? So anyway, so that's pretty much it for that. So hopefully that gives you guys some clarification. If you have other questions, though, feel free to let me know. Otherwise, I want to get into the actual medications themselves. All right, so we are talking about opiates. Opioids, opiates, kind of similar names for the same thing. We are, and is this a slide I left off on? Actually, no, I think I was able to talk through the mechanism. Oh yeah, we talked about addiction and all of that. Let me actually get into the real drugs themselves. Here we go. All right, let's start off here. Where we're at, I believe. You guys can contradict me if you like, but so first off, start with codeine. Codeine is pretty much one of the kind of wimpiest opioids that we have out there. It's considered one of like the natural opioids that comes as a derivative from that poppy plant itself. So when you think about natural opioids, you can think about like heroin and morphine and codeine. They're all very similar to one another. And so codeine itself is not very good as an analgesic, but it does get converted over into morphine via this enzyme CYP2D6, which we've probably talked about very briefly. What's interesting, though, is there's a lot of pharmacogenetic variability in how much CYP2D6 that a patient is going to be expressing. So you'll find some people are very hyperactive in terms of metabolism, so they convert a lot of codeine into morphine, and they will have good or exaggerated analgesic effects. In the other case, though, you may have patients who are deficient in that enzyme, and they don't convert a lot of it over, and thus they don't really get a whole lot of analgesic activity out of that. So because of some adverse effects that have happened here, because of, just the variability in patient response, I'm seeing this really go out of vogue, especially in children. So you may see this being used less frequently, unless you have a patient who's been on it for years and it just works for them. It just really depends there. But this would be more so for like mild to moderate sorts of pain you'd be dealing with. Now, again, I'm not going to cover on each one of these which ones come orally or IV. I do expect you to look that stuff up on your prescription assignment. So look up, if you're writing for an oral pain med, and it actually does not have an oral dosage form, then I'm going to count off on that, right? So I want you to be looking for those kind of details. Um, and I'm not going to ask you specifically which ones are a C5 or a C3. I would expect you to know the differences and what that means in terms of prescribing, just like we talked about last time. So if I mentioned a C2 medication, I would tell you that it's a C2. And what does that imply in terms of its prescribing for that? I would not ask you specifically whether codeine is a C5 or C2. That's not really what I'm hoping to get out of this, right? Kind of interesting though, that black box warning is for those patients who do have ultra rapid metabolizing. So they convert way too much of that codeine to morphine, and it's led to death sometimes because, as you mentioned, respiratory depression is going to be one of the big dangerous things you're going to see with opioids, which we'll cover in just a little bit. Interestingly enough, though, it actually has a predilection to occur in patients who have sort of like a Middle Eastern or North African descent, which is interesting. Because I do find that patients, especially with sickle cell disease, who are predominantly black, do have pretty good responses to codeine. So maybe there is some bit of a correlation there. But yeah, so for most children's hospitals, this has just been removed off of the formulary altogether. You may still see it used for some adults, but it's really kind of variable. Pretty wimpy stuff. But morphine, though, is pretty consistent. You're going to find this used all the time, especially on the inpatient side of things. There's going to be a lot of different forms that are out there, so some of which will be IV. On the PO side, it's important to consider whether a medication is an immediate release product or an extended release product. The difference there obviously being how quick and how long it's going to be working for. And this kind of goes back to when we were talking about medications being used for either kind of baseline, that basal amount of pain patients may be experiencing, and then acute pain or breakthrough pain they're having on top of that. So you may find patients who may be on two different morphine scripts. One is the ER formulation, which is normally called MS Cotton, stands for morphine sulfate. They may be on that, say, twice daily in order to cover them for their basal amount of pain, and then they'll be on an immediate release morphine for breakthrough pain. So they may be on that, how many ever milligrams, Q3 hours, PRM breakthrough pain, right? That way they have the two there going, one's covering the basal pain, one for breakthrough. There can be some differences in terms of metabolism for some patients. You can actually have some people that will have kind of poor ability to clear these metabolites, and in some cases they are active, meaning that you could have a patient who is metabolizing morphine into this morphine 6-glucuronide, and if they have bad kidney function, they're going to accumulate that, and that actually can lead to oversedation, respiratory depression, and all of that. So you do want to be cautious in patients with renal failure, especially elderly patients who are taking morphine, because this can be a problem. Is it going to be an issue if it's, a couple of days in the hospital? Probably not, but this is more for long-term sort of chronic use. Okay. Another big thing you're going to see with morphine is it does cause a significant amount of histamine release for many patients, and so they will develop, or they may develop rash, itching, things like that. It's not really an allergic reaction. It's not really an anaphylactoid reaction that they're experiencing. In those cases there, you can either switch to a different agent that does not cause a lot of histamine release. I'll give you some options there in a little bit, or you can pre-treat with antihistamines, right? So you can give them like a Benadryl or something. Keep in mind though, Benadryl and other antihistamines are going to be sedating, and so is morphine. So if you have that two kind of kind of synergizing with one another, you can run into issues with that, causing oversedation for those patients. So I would say probably most often just switch to a different agent if it's going to be a problem for that person. Up next, we have hydrocodone. This used to be, it might still be, I think it's kind of gone down a little bit, but it used to be the #1 most prescribed drug in the US. It was a huge mover back when it was a C3, back when it didn't have quite as many restrictions on its prescribing as we see nowadays. But anyway, so this is hydrocodone. It frequently is going to come in combination with acetaminophen. So if you see like a hydrocodone acetaminophen combo, that's usual. That's the most common you're going to see there. There is like an extended release form by itself, but it's very uncommon you're going to run into that unless you're dealing with chronic pain patients. So what's really important with that is you have to make sure that the patient knows how much acetaminophen they can take in conjunction with this. And frequently you just tell them not to take any acetaminophen outside of this hydrocodone product because of the risk for having liver dysfunction, okay? especially if patients are self-medicating, they can really run into problems with this. And I've had cases where, from a toxicology standpoint, you normally think about overdoses with this stuff, but I've had people who just have legitimate pain issues and they were self-medicating and got themselves into a lot of trouble with their liver because they were using hydrocodone products that contain acetaminophen on top of OTC acetaminophen, basically. It's it was not intentional to harm themselves in that case there, but it ended up happening regardless. So not an ideal thing there. Interestingly, this one is converted to hydromorphone or Dilaudid, which we'll look at in another few moments here via CYP2D6. But you're going to find that there's less variability and less clinical significance of this interaction than we saw for codeine. So there's no similar black box warnings for this as you would see with codeine. So that's one kind of notable difference there. And again, since we've made changes to how we prescribe this, mainly because we made it into a C2, so it's much more restrictive because we saw there's so much abuse going on with it, that has led to it being at least prescribed in fewer numbers, or at least in fewer total pills. Just like we saw with that House bill last time we met, talking about how we can only do it for like 3 days or maybe up to 7 for acute pain issues. That has really curtailed a lot of the use there. And again, when I worked as a student, as an intern at CVS, for instance, you'd have people coming up to the counter all the time that would say, hey, I got this prescription here from the ER. Can you go ahead and fill it? And it'd look going to be, an antibiotic for a dental infection and then Lortab. And I said, okay, do you want both of these? And they said, no, just the Lortab. I said, okay, well, you don't want the antibiotic for the tooth infection. And they said, nope, just the Lortab, right? So question of, how legitimate some of these patients are, it can be questionable, but again, that has certainly gone down in years as a result of some of these changes. Not curtail all abuse, but it has helped, at least to a degree. Up next, we have oxycodone. You can either find it by itself or frequently in combination with acetaminophen. So with acetaminophen, it's usually called Percocet. I'm sure most people have heard of Percocets before. But we also have a lot of some long-acting formulations as well. This is where you get into your OxyContin. OxyContin is typically the long-acting form people will be on, and then maybe on like Percocet for breakthrough pain as an example there. So you'll find some issues with oxycodone, and in fact, if you look up some documentaries or some news stories, you'll see OxyContin is really like one of the big reasons for the opioid epidemic nowadays, and some of the pharmaceutical push behind that. I'm not going to get into all of it here, but it is pretty interesting, kind of sad for a lot of these patients who have developed addiction as a result of use of some of these medications here. But still useful for patients who have legitimate pain concerns and need either immediate relief of pain or for chronic pain with OxyContin. Note here that this has been a C2 for like forever. So back in the day, before hydrocodone was made into a C2, everyone just prescribed hydrocodone because there wasn't as many restrictions on it. But now that hydrocodone's been bumped up to a C2, you can kind of think of oxycodone and hydrocodone sort of very similar in terms of their actions and in terms of picking one versus the other. You may find some people respond better to one or the other, but it's really just going to be a luck of the draw at that point there. But you can kind of think about these two fairly synonymous with one another. All right. So then getting into hydromorphone, in terms of like oral opioids, those are probably the most common ones you're going to run into. So codeine, morphine, hydrocodone, oxycodone. Hydrocodone, oxy are like basically only oral options that you're going to see out there. Now we're going to get into stuff you might see more often, like in a surgical setting or in the inpatient setting. Certainly see a lot of morphine, but now you'll also have like hydromorphone to deal with. Some patients may be on oral Dilaudid outside of, on the outpatient basis there, but it's not as frequent. Anyway, we're going to see here that some benefit of using hydromorphone for patients is that it does have a relatively short half-life compared to morphine. So if you only need analgesia for a relatively short period of time, say like in the post-operative setting or something like that, if it was a minor procedure, this can be helpful from that standpoint. So you also want to think about the kinetics and how long these drugs are working when trying to decide which one to use for a patient, right? Shorter half-life also means shorter time for side effects, you'll see with this. This also has a lot less histamine release than you would see with morphine. So if I had someone who said they had a history of itching and rash with morphine and you determine it was an anaphylactic reaction, then hydromorphone's a pretty good option to go to in a lot of cases there. So I'm starting to see a lot more use here for this stuff. I think for a long time it had kind of like a bad rap in terms of like how strong it was, but everything is relatively equally safe as long as you're using it in the appropriate doses there. So as more people get activity or get experience with it, they're more likely to prescribe it. So one thing to note with that is you're going to see a lot of dilaudid use that's out there. Right? Up next is fentanyl. Fentanyl is really interesting. This one is probably one you'd see most frequently, like in a surgical type of setting. However, you're seeing increased use throughout all kind of aspects of pain management here. This is like kind of what we call a synthetic opioids. This has really no degree of similarity in terms of chemical structure to a lot of the original opioids that we have there, like morphine and things like that. So if you have a patient who has an allergy to morphine, for instance, and it is a true anaphylaxis, it's not just that histamine release, you don't want to use anything that has a very similar chemical structure because there's a chance it could have a cross reaction there. So if someone did have a reaction to morphine that was anaphylactic in nature, then I would probably say to go with something that is fully synthetic, that has no similarity in shape, but still acts on those mu opioid receptors. And so fentanyl is kind of like the first option here that would be really good for that. Or if they had like, an allergic reaction to hydromorphone or oxycodone or any of those, fentanyl can be a good option there. However, it is really, really potent, so you want to make sure you're looking at the dose you're administering to these patients here, like 100 times more potent than morphine. So just to give you an example, when we talked about equipotency between drugs, and I know I mentioned this back in the intro course in the summertime, but something like, say a patient getting an IV dose of morphine versus fentanyl, let's say 2 to 4 milligrams of IV morphine, so milligrams of IV morphine, is roughly equivalent to, let's say, 50 to 100 micrograms of fentanyl, right? So 50 to 100 micrograms, so it's a much, much smaller dose you're administering, and it's important to keep that in mind. If you were to write for, say, 2 to 4 milligrams of fentanyl that was administered to the patient, that would kill them. They'd just stop breathing and be dead, right? So you do want to be cautious and get familiar with these drugs because, know what a normal dose sort of looks like when you're dealing with this in the clinical setting, right? So as you get there in your clinicals, look at the charts and look to see what kind of a normal sort of dose is. You'll get a feel for this stuff after a while. You see it enough times. Now, fentanyl is kind of interesting. Most of the time you're going to see it being used in an IV formulation. So we see this in surgical settings and patient settings. But you also have different types of formulations that can be used for more chronic sorts of pain. So for instance, we have things like transdermal fentanyl, or transmucosal fentanyl occasionally. So transdermal would be like the Duragesic patch you find there. So patients can apply the patch to the skin and allow them to get sort of long-lasting opioid effects 24/7 until they change the patch. Transmucosal, there's actually a buccal formulation. You can see an example here. This is what I call the fentanyl lollipop, where basically as patients have pain, they can basically put this on the inside of the cheek. They'll absorb the fentanyl, and then once the pain has resolved, they can take it out. Obviously, I take some umbrage with this as a toxicologist because I worry about kids getting into something like this. So I would be very, very cautious if you ever see that pop up there. And so typically, fentanyl has a fairly short half-life, but you'll find too that with agents that do have a short half-life, they're also good for continuous infusions because they're easily able to be titrated, right? So you'll see this a lot for patients who are like, say, going to the ICU, they've been intubated, and they need to be on some sort of sedation. They'll probably be on fentanyl most of the time. You may find a few others, but fentanyl is pretty common for that because it has a short half-life. So as I dial the dose up or down, the patient's going to have a pretty quick response to that because they'll hit steady state that much faster there. Okay. There are a few cousins to fentanyl you're going to find there. So my dad, he's probably just as or even more corny than I am, but he was a CRNA for 1,000 years, I think. And so he would always talk about fentanyl and fentanyl's cousins, Al, Sue, and Remy. So that's how I remember the different fentanyl derivatives here. So there's alfentanil, sufentanil, and remifentanil. Those are more often just used in the surgical setting. They all have a pretty similar profile. So if you see those, you can kind of think about them in similar activity of fentanyl. If you talk to someone who works in anesthesia, they would tell you that yes, there's huge differences between them, but for our purposes, they're practically pretty similar to one another. Okay. And so as I mentioned, people have true allergies, and so this is phenanthrene is basically the chemical classification for all those opioids like morphine and oxycodone. If they have a reaction to those drugs, then fentanyl is a really good alternative to that. Okay, so morphine, codeine, hydromorphone, oxycodone, any of those, they have a reaction to that, a true anaphylactic reaction, then yeah, fentanyl would be a good alternative because the chemical structures are completely different. I'm not going to bore you by putting those up there, but at least you get the idea. All right. Up next is going to be methadone. Methadone's really interesting, and I'm sure most people have heard of things like methadone clinics before. This is kind of another synthetic opioid here that's been used for many, many years. Its sort of claim to fame is its really long-lasting effects. So you can see here the half-life for this is something like greater than 50 hours. Okay. So what you're going to find is that this is really good for more chronic pain management. This would not be used for acute treatment of pain. Okay. Something short acting you'd want to use for acute pain. So fentanyl is good for acute pain. Something like methadone is really going to be better for more chronic pain issues because it's really long lasting. You can see here has a kind of a few novel mechanisms here. It also has some effects on serotonin and norepinephrine. We're going to get into that later when we talk about neuropathic pain, but this is one reason why this may be able to be helpful with that, and we'll get into more of the neurotransmitters and neuro and behavioral sections a little bit later on, but just you'll get the idea here. But it may be useful for some neuropathic pains, but it's really the mu effects that we're focusing on, right? So what you would see, and kind of this is why this was popular for use for addiction management for a long time, was because of really long half-life. So say you have the methadone clinic, it's only open Monday through Friday. Basically what patients would do is they would go in Monday, Tuesday, Wednesday, Thursday, Friday, get their dose of methadone, right? So that you wouldn't prescribe this for them outpatient because you'd worry about them taking too much. And so they'd have to go to the clinic in order to get their dose. So what you'd find is over the week, the levels in their body would build up to a point where as the weekend hit and the clinic is closed, they would have a relatively high level of the drug. And then that way it would hopefully prevent withdrawal reactions and keep them from falling off the wagon, so to speak, right? That way they would not have strong cravings and they would hopefully not revert back and go to whatever opioid they used to use. And then they would be fine for when Monday hit. And again, Monday at the methadone clinic is always really hopping because everyone's starting to have those withdrawal symptoms starting to come back and they want to get in there and get their dose so they can start the cycle over again. The idea would be to try to wean them down on their dose over the course of many months or years. That way they can hopefully be opioid free at a point. So that's sort of the classic use for the drug there for opioid use disorders. However, nowadays we're starting to see more and more use for chronic pain because there's nothing magical about methadone's use for opioid addiction. It's just that it has a long half-life. We could do that too for patients, especially with like chronic pain issues. They have cancer, for instance. So just because someone's on methadone does not mean that they have an addiction, right? It could just mean they have chronic pain issues that the long half-life is well suited for there. One thing I'm not going to get into right now is the idea of conversion between different types of opioids. Just know that with methadone, it gets a little hairy in terms of finding equivalent doses. If you're, say, admitting a patient and trying to convert them from methadone over to oxycodone, for instance, but so it can be a little bit of a challenge. That's why people specialize in pain management, whether they're being providers or pharmacists or whatever the case is. So make sure you're using good resources when trying to convert between different types of opioids there. Another unique thing for methadone as well is it does prolong the QT interval. So you would definitely want to make sure they don't have other meds. They can prolong QT, make sure they don't have a baseline QT prolongation because it could induce torsades. I've not seen methadone cause torsades too frequently, but again, it's either an overdose or if they're on multiple meds, they're all prolong the QTs when things get a little bit more dicey there, okay? A couple other opioids you may see occasionally is going to be meperidine or Demerol. This is most likely going to be seen in the surgical sort of setting, and we don't like its use a lot. I had a pain management pharmacist who taught in my school, and they called it Demonol instead of Demerol because they hated the drug so bad. It had a lot of problems, especially in elderly patients, because there are some toxic metabolites that if you're old and you could not clear, you didn't have good renal function, you could build up levels of these metabolites and could lead to seizures and things like that. So they didn't like it from that standpoint. However, we do see it used occasionally for what we call rigors in the surgical setting. So rigors basically mean shivering. And so when this comes up, and I'll tell you, at least from an ER standpoint, I've seen this come up when we try to do therapeutic hypothermia. So say someone has a cardiac arrest and they need to be cooled down in order to hopefully, keep some brain function. One of the things you're going to find is that as your body gets cold, it tries to shiver to heat itself up, right? And so that's going to be kind of going in the opposite direction of what you want to do in terms of body temperature. So we'll sometimes give meperidine in order to try to prevent that shivering. You can find shivering is kind of a common thing, relatively speaking, after surgery. So this is used occasionally in that setting there, but this should not be used for routine pain management purposes. Okay. Also, some drug interactions with it as well. We haven't talked about monoamine oxidase, but it's a MAO you see there. And that is an enzyme that's responsible for metabolizing a class of neurotransmitters called catecholamines, which includes things like norepinephrine, epinephrine, serotonin, even dopamine to a small degree. And so monoamine oxidase, if you inhibit that, you can end up with increased levels of those neurotransmitters, right? Probably not a problem by itself, but if you have patients who are on, say, like medications for depression that also increase levels of serotonin, you can find synergy here and they can lead to side effects. I'm going to get much more into that in the behavioral section coming up probably in a couple of weeks. So just kind of keep that in the back of your mind in terms of that sort of interaction you'll see there. Another question here. Someone said, for opioids, would we consider their dose in the hospital as their loading doses, or does it still take 4 to 5 half-lives to get them to steady state? Or are we just concerned about pain resolution in opioids? We don't frequently give loading doses of opioids unless it's like in specific settings. So, as an example of cases there, for instance, if you were to have a patient who is going to be intubated and they would need sedation, including an opioid, you may give kind of like a bolus dose up front, followed by a continuous infusion. But for the most part, you're not going to be giving loading doses of the opioids. You're going to give it time to sort of get to steady state. And again, you're looking at their pain scales. Like you're seeing how their pain is resolving on its own. So for instance, that's why you have orders written that will say, okay, for severe pain. So that way, if you go to the patient and say, well, how do you rate your pain? And typically, like severe pain, you would say is like a 7 to 10 out of 10 on the pain scale, right? So they come in, they say they're an 8. Then okay, well, they're still having pain. They can still get more opioids. They can get another dose. So typically, we're not doing half-lives, or we're not going to be doing loading doses for these drugs for the chance that we could potentially go too heavy on it and over-sedate the patients. I probably would not do. But good thought. Most of them have such a short half-life that it doesn't really matter. That 4 to 5 half-lives is a short period of time as opposed to something like methadone, which would take quite a while, but that's okay. We don't mind if it takes a while because we're also monitoring for other things. They may have PRN medications for breakthrough pain, in order to kind of get them through that period until it does get to steady state there, right? Anyway, meperidine, not a great drug, but does have its use for rigor specifically. That's what you'll see it used probably nowadays 10 times out of 10. That one's pretty interesting, and this is going to be important for your use potentially, is going to be buprenorphine. So this is really kind of the big alternative to methadone that we're seeing nowadays, and it's kind of has the benefit of, whereas with like methadone, you're primarily going to be seeing that used for addiction purposes in like pain management clinics or like actual addiction treatment centers. And PAs are not going to be basically allowed, at least in Florida, to prescribe methadone, because if you're working in like an addiction treatment place or pain management place, the law requires that the attending provider does that. However, you guys as PAs will be able to get what they call a MAT waiver, and it's called medication assisted treatment. It's a free 24-hour education thing that you can do online. I'm not sure if your school recommend or requires you to do that. I know we do over at Nova. So they do part of it during their didactic year and part in the clinical year. But they get this MAT waiver, and then by the time you get your license and you get a DEA license, you're able to get what they call an X waiver that allows you to prescribe buprenorphine for opioid addiction purposes, because you'll be seeing these patients in the family care setting, in the primary care setting. So this is something you might be dealing with, and so it's important to know about it. That's why they have you do that training for it. But anyway, the buprenorphine, why is this one different than methadone? Well, basically, it has a long half-life, so makes sense. It's good for helping to prevent withdrawal symptoms. But also it's a partial agonist. So what's interesting with that, that someone taking this is not going to get the full effects of an opioid like they would with heroin or fentanyl or something like that, but they will get at least enough activity to try to prevent them from going into withdrawals. That's the goal here, right? Because if you're going into withdrawals, you're going to be craving that medication. You're going to go back to it in order to get rid of those withdrawal symptoms because it's so miserable to be withdrawing from these opioids. So by giving a partial agonist, it's going to help to ameliorate those withdrawal symptoms and hopefully keep them from kind of going back to whatever their drug of choice was. Okay. Um, so this is the primary uses for opioid addiction treatment purposes. Okay. And so you'll find a couple different varieties. There's just regular buprenorphine by itself, which is Subutex, but there's also one that contains naloxone as well. We'll talk about naloxone a little bit, but this is basically the rescue medication. And it's combined the two together because it actually prevents people from trying to abuse it IV. I'll get a little bit more into detail on that in just a few minutes here. But big thing here, partial agonist is going to prevent those withdrawal symptoms, or at least try to prevent them. The other big thing with this too is that because this has a really tight binding affinity, meaning it really loves to bind to that opioid receptor, it can kick other opioids off of that receptor. Okay. So that can be a problem if someone's having like full dose opioids on board and then they take buprenorphine and it kicks those opioids off the receptors, and all of a sudden they can actually induce withdrawal. Kind of interesting. So I'll give you an example. We had one lady that came in. EMS says, okay, we have someone coming in for a buprenorphine overdose, Suboxone overdose. And so what I would expect to see coming through the door is someone who is very sedate. Perhaps they're intubated because they're not breathing on their own. And we would have to treat that with the rescue medication. This lady came in and she was in 4-point restraint. She was trying to bite, spit, cussing, she was in a total mess. And so we're like, okay, well, that doesn't look like an overdose on buprenorphine. Like, what is going on here? So once we got her calmed down, it turns out that was the fact that she normally was taking methadone, but she was kind of taking higher doses than she should because she liked the feeling of it. But then she ran out. So in order to get some kind of opioid activity, she used her roommate's buprenorphine. So not realizing that as a partial agonist, it's going to kick all of that methadone off of the receptor. And so instead of getting 100%, opioid activity, now she's down to like 50%. That big drop in activity is what led to the withdrawal symptoms that she was experiencing. So even though it was an overdose, she's actually having less opioid activity than she would have had otherwise. So that's an interaction. It's good to know. That's why we tell people that are getting Suboxone, like, listen, you need to stop taking your opioids, whatever you're using, whether it's heroin or otherwise. And then once you start to have withdrawal symptoms, then we initiate buprenorphine because it will help then to try to help curb those a little bit. And then that's when you kind of start the real treatment with it. So hope that makes sense. If not, let me know and I can kind of go over more details there. So those are the main opioid agonists you're going to be running into. How you pick an agent there is going to be based on a lot of factors. So it could be based on organ function. It could be based on the pain intensity that they're experiencing. If I have someone who comes in and they have an open femur fracture, codeine's just not going to cut it, right? It's just going to be too wimpy in terms of its activity. Hydromorphone, fentanyl, morphine, those would be totally reasonable, right? Also think about the dosage form that you want to use. If someone's coming in with that open femur fracture and I give them an oral medication, that's not really going to be kicking in fast enough for that patient there. They probably are going to want something more fast acting. That's why you go something IV in those cases there. So, your fentanyls and hydromorphones. And so typically for persistent pain, you want to have a long-acting medication on board for basal pain management, and then you want to have a short-acting on top of that PRN for breakthrough pain. So it would not be uncommon to see someone who's on Oxycontin, which is extended release oxycodone, Q8 hours for basal pain control, and then they'll be on, let's say, morphine, immediate release, Q3 hours, PRN breakthrough pain, right? That might be something you'd see like that. Generally, oral is going to be preferred. Unless they're having really severe pain, if they're in an inpatient setting. If you need something long acting for an outpatient, that's where the transdermal route for fentanyl can be utilized. So if you have some of the chronic pain issues that need to be discharged, you could utilize like a transdermal fentanyl. That could be a good option there. And then one kind of interesting thing we can do, we do this a lot in the peds side of things, especially in the ER, for patients who, kids, even some adults can be quite needle phobic. So if we're having a hard time getting an IV started because the patient's so anxious or having so much pain they won't sit still, we can actually do intranasal fentanyl, and that can allow us to get some pain control on board, chill them out a little bit, and then get the IV started. So different ways we can go about getting these opioids into patients there. Dosing should be individualized. So generally want to do a start low and go slow sort of mantra here, and titrate as needed. Just remember, you can always give more medication. Once it's in, you can't really take it back, okay? So obviously, if they're coming in and they have that open femur fracture and they're screaming their head off, you know, you don't want to say, well, let me just go ahead and give you a little bit of oral codeine, see how that takes the edge off, and then if that doesn't work, we're gonna, like, okay, you can jump the gun a little bit in some cases where it's appropriate, but again, it's okay to be a little bit more cautious and careful with these drugs because there are significant number of side effects associated with them, which we're going to get into. So we talked a little bit about PCAs earlier. So this stands for patient-controlled analgesia. We're starting to see a lot of use of this, especially like in the surgical setting, for patients who are within enough to be able to utilize the PCA. We can do this, and it helps with opioid sparing. So instead of like a nurse having to evaluate a patient, determine if they need medications or not, this allows the patient to determine if they need it, basically. Okay. And so we're seeing this quite frequently. I didn't want to do it for the prescription assignment because I thought it might be a little complicated for our first one there. But basically, as I mentioned, it's a pump that's set up that can either provide a basal amount of drug, so how many ever milligrams per hour, and then there'll be an on-demand dose that you can give as well. So they can hit the button and give themselves a dose. Now, they can't just keep hitting the button and get doses forever because then they could kill themselves that way, right? So there is what we call a lockout interval, and that will provide a period of time where even if they hit the button, they can't get any more drug there. So as an example, if you had a morphine PCA, you could do a 1 milligram per hour basal rate with 0.5 milligrams every 15 minutes on demand. They would get a milligram per hour no matter what, and then on top of that, they could hit the button every 15 minutes and get 0.5. Now, the handy thing with these pumps here is it also documents how many times the patient presses the button. So if someone is pressing the button every 10 minutes, that probably gives you an idea that they're not getting enough pain control because they're hitting it too soon because they're in pain, right? Maybe you want to modify the dose up some. Or if you notice they're never hitting the button, then maybe they're getting really adequate pain control. Maybe you try going down a little bit to see how they do at that point. Because again, the idea is to get them off of the opioids when you can. In some cases, especially in pediatrics, it's kind of funny because the nurse will document that the patient had like 564 button presses in the hour. And you're just like, well, what in the heck's going on with that? Is the patient like, on the ceiling in pain? And no, they just like pressing the buttons. They sit there and keep clicking it. So obviously you got to take it with a grain of salt, but that's roughly how we do PCAs. Clinical setting. Someone says, how do we determine which opioid to use for pain relief again if we're not familiar empirically with what is stronger than the other? Can you list some increasing strength again or explain how we might determine that? Yeah, and you'll see that too when you're looking at like Lexicomp, wherever you're going to get your drug dosing information from. You'll get it'll tell you like for severe pain, for mild, moderate pain, and that will give you a clue. So generally speaking, if you're going from like kind of lowest to highest, you would say, acetaminophen is probably like the lowest on the rung there, okay? And then you have your NSAIDs, okay? Then you have like something like Toradol, which is IV NSAID we talked about, having pretty good opioid-sparing effects. Then getting into the opioids, codeine's probably the wimpiest one you're going to get into, right? Next, I'd probably say something like oxy and hydrocodone from an oral standpoint. Oral morphine could be in that same category there. And then a step up above that, so we start getting to the IV therapy. So at that point, morphine, fentanyl, hydromorphone, all those are going to be in the same kind of ballpark. Okay. Again, you can get equipotent dosages. So even though fentanyl is more potent because you're dosing at micrograms, doesn't mean that it's any better of a pain treatment than morphine might be. You just got to find the right dose for the right patient, right? That's generally how it would go. And again, I'm not looking for perfection here. I'm just looking to get you experience doing it. And I will provide feedback if you pick something that's like totally wildly off base. Okay. So do your research, try to intuit, what makes sense. Look at protocols that are online. Someone posted one from Cincinnati Children's Hospital, for example. You can look that stuff up and see, okay, what are other people doing? Right? Because you're not trying to reinvent the wheel here. If someone's got a really good means of doing something, then check it out. See if it works for you. And if it does, go for it, right? No point trying to come up with something brand new for no good reason. Hopefully that helps. All right. Here's an example of what this PCA pump would look like. Here's basically the controller. The patient would have the button on it. You can see the medication being infused through here. And then the nurse can program in all the settings that you would write into your order there. So how you would write this out is basically you would write the basal rate of drug per hour. You'd put the demand dose they're going to be getting, and then the lockout interval. So it would say 0.5 milligrams every 15 minutes, for instance. And then as another component, we always put down the total amount used during a 4-hour period. This way we can try to calculate out, say what's the most that they could get during this 4-hour period to make sure that we're giving enough in that syringe for them to actually get that without having to change it out early, just from a logistical standpoint. So as an example, as I mentioned, you do morphine IV PCA, to be the first line of the order, basal rate 1 milligram per hour, demand dose 0.5 milligrams every 15 minutes. So that way they get a maximum of 4 doses per hour. And then you could just calculate the 4-hour amount based on the basal rate plus the demand doses that they could get. So you'd say, okay, 12 milligram would be the 4-hour max, basically. Again, you'll see these orders in the clinical setting. I'm not going to ask you specifically, okay, calculate the 4-hour max on this, because it's easy enough. You guys can do that. But just to give you an example what this would look like. Okay, so let's talk about adverse effects. I should have gone over these first, but that's okay. Frequently, you're going to run into constipation. Most patients are going to have some degree of constipation associated with these meds here. On the prescription assignment, could have put in information about adding in a bowel regimen, including some laxatives. We'll talk about that in a few moments. But constipation is very common. Sedation is going to be pretty common with these drugs as well, right? All of these are going to be sedating. All opioids are sedating. And then, as I mentioned, the histamine relief is going to be mostly seen with morphine. So if someone does have significant itching, rash associated with morphine, utilize something like fentanyl is going to be a good option for those patients, or something like hydromorphone. Those are going to be fine. They're not going to get nearly as much histamine release associated with that. Less frequent we're going to find are going to be this kind of altered mental status, this delirium that can happen here, and there's risk for a respiratory depression. This should be minimal if you're going with relatively conservative dosing, but it's a problem where you run into people are getting too aggressive, or there are multiple medications that are sedating. You can run into respiratory depression, and this is what kills the patients, right? This is what actually leads to the demise of them. They can be asleep, have no problem. It's when they stop breathing is when we get a little concerned about that. It's all part of the ABCs, airway breathing, right? That's what we want to keep going there. And then we talked about risk of abuse and diversion as related to the addictive properties of these opioids. Again, all of them are addictive. It does not matter which one you're dealing with. If it activates the mu receptor, they are all addictive. Now, abuse is when someone is basically using the drug outside of what you recommended. So if they're taking 2 tablets when you told them to take 1, that's considered abuse because they're doing it for some purpose, whether it's to adequately manage their pain or because they like the feeling, or the case may be. Diversion is going to be something on the healthcare professional side. So this is where someone says, okay, well, I have a syringe that has 2 milligrams of morphine in it. I gave 1 to my patient. I'm supposed to waste the other 1 milligram. I'm just going to take it for myself, right? That is unfortunately something that you will find with healthcare providers. You think that we'd all be perfect, but that's not the case. And what's interesting is if you look at the data on it, the people most likely to be diverting opioids in order to use them themselves is actually anesthesia providers. They tend to be the most likely ones to abuse these drugs here. If they are diverting it in order to sell, it's actually pharmacy personnel that are more likely to do that. So interesting stuff there in terms of just the human behavior and psychology behind some of this. But definitely something we look at very closely. We look at things like usage patterns in the hospital to make sure that there's not like one nurse who's like always giving pain meds for patients on the floor. That's kind of, we look for kind of red flags there to make sure there's no diversion stuff going on. Okay, someone said, can you give an example of which opioids would go to the different situations? Yeah, so if I had someone who's having like severe acute pain, so if they came in and they say, I'm a 9 out of 10, I'm a 10 out of 10, I'd probably go something IV, right? Probably go something like, fentanyl, hydromorphone, morphine, any of those are fine, right? If it was something like, they come in and they have, let's say they have some abdominal pain or something, they may require IV medications. If it's more moderate, then, something like an oral medication might be reasonable for that, right? It really just depends on the situation, how severe it is. So IV is going to be more for the really severe pain. That's why I said more oral options for more moderate to mild pain. So you'll get a feel for it. I can't spell it out for you. I can't give you all the answers. Come on. It's a part of the fun is trying to figure it out yourself to a degree, and then I give you that feedback. Someone said because constipation is such a frequent adverse reaction with opioids, what is the go-to laxative option? Are there any that are contraindicated? I'm not sure do I talk about that specifically? Yes, I do have a whole page just on constipation. One of your pharmacy techs at my old job got fired for that. Actually, there was a hospital that when I did one of my rotations at, and there was a pharmacist there. He was like the quintessential like surfer dude. It was like a beaches hospital, or hospital at the beaches, and most laid back guy ever. But he was a nurse who then eventually became a pharmacist. And so he worked in the ER, and what was wild was that he would actually go and give the medications himself because he had his nursing license. And so there's one night I was shadowing him in the ER, and I was just like, "That's real weird." I thought, as if we're working as a pharmacist, we don't do the duties of other jobs. He's like, "No, it's fine, it's fine. You know, I'm a nurse. You know, so I can do this." And so, years later, I saw on the news that he actually got busted for diversion. And so again, if something doesn't feel right, you should investigate that, because again, you want to make sure. It never hurts to ask questions, but it was just something weird. I was just like, man, this is strange. But I was a student, I didn't know any better. But it turned out to be a correct feeling there. Anyway, so I'm gonna talk about constipation in a moment here. Some ways we can try to minimize adverse effects includes, again, go slow when titrating on these things here, and then determine the cause of symptoms. Look at the reason, if they're getting the itching and you're giving them morphine, well, that makes really easy sense right there, right? And then you can try either changing the regimen they're on, the actual drug. You can change the dosing route that they're getting, things like that, in order to help try to manage adverse effects. The not ideal situation is to treat side effects of drugs with more drugs. I always hate when we have to do that. Again, it's job security for me if everyone was on a ton of drugs, but it's not best for the patient. So try to minimize the amount of meds we're going to need here. That's why I said, if they're on morphine and they're having itching, yeah, you can give them antihistamine, but that increases risk for sedation, some small risk of respiratory depression there. So like, just switch them over to a different opioid that doesn't do that, and then you're done. So again, fewer drugs is better in general. And then, as I mentioned, tolerance will develop to a lot of the side effects. So, for instance, you could have someone who's taking really heavy doses of opioids all the time, and they could develop tolerance to those sedation effects, and they could be having a normal conversation like we are right now. However, some things they will never develop tolerance to. So, things like the constipation, that's always going to be present. That's why we're going to acquire what we call the mush and push sort of mantra here. So, let's get into that. Sounds kind of gross, but that's kind of is what it is. So again, as we mentioned, these patients may not just be on opioids that are slowing down the GI tract. They could be on calcium channel blockers. They could be on anticholinergics. They could get all kinds of things that cause constipation. So this is a really big issue here you'll find with these people. And so we want to make sure we're getting this managed, because you can have a patient who's coming in for chronic pain, who is just complaining all this like belly pain they're having. And you're like, okay, well, they're not getting their pain dealt with. Let's go ahead and increase the amount of opioids that they're on, right, to deal with this pain. And it turns out it's just abdominal pain because they're so constipated. They haven't had a bowel movement in 2 weeks. Those are the things you want to consider. So in this case here, obviously giving fluid and fiber is important. If they need like fiber supplements, like, methylcellulose or something. We talked about this last semester. But oftentimes we're going to do prophylactic opioid or bowel regimens, we'll call them. So typically they include a mush and push mantra. Mush means a stool softener. That includes things like Docusate most frequently. And then push is a stimulant laxative. So something like Senna, something like Bisacodyl would be recommended there. So it's not uncommon for patients, especially in the post-operative setting, to have their opioids on there. And then they'd also be on Senna and Docusate, for instance, together in order to make sure that they are moving along. Because again, ileus is a thing that can happen after surgery. So you want to make sure that's not a surgical issue that just popped up. You want to make sure that the opioid's not going to be kind of clouding the picture there. And again, having a bowel movement or passing gas or something is a good sign for when trying to determine if someone can be discharged after surgery, because again, you want to make sure things are moving along. You may be able to utilize other laxatives as well. So an osmotic laxative, like a polyethylene glycol, Camurelax, can be useful here. But in general, mush and push is kind of the way to go. For chronic patients, if you recall, we don't like to use stimulant laxatives chronically, but so if you can minimize how often they're having to use that, that's going to also be beneficial to their bowel movement activity. So hopefully, so other person was asking, is there anything that's contraindicating use of these? Not really, but again, the mush and push is kind of what you want to go with in terms of modalities there. Yeah. So let's talk about antagonists real quick here. So basically, these are going to be the rescue medications that block the activity of opioids at the mu receptor to basically put them into withdrawal immediately, as it turns out, but it also helps to reverse the respiratory and CNS depression. So there's a movie clip you can look up. It does have some curse words. So again, if you're sensitive to that, I would not look it up. But there's a movie called Bringing Out the Dead. I believe like from the 90s or something. But look up Narcan Reversal. and you can get a video that is pretty true to life in terms. It's kind of funny as well, but it's kind of true to life in terms of how quickly Narcan works to wake these patients up. If you've never seen it, it is like an exorcism basically, for someone who's like truly overdosed on opioids. So what we see here in naloxone's the primary one we're going to deal with. Narcan's the common brand name we're going to see there. This one has to be either be given IV, IM, or intranasal because it does not absorb. It does not get absorbed at all from the oral route. And this has really fast onset. So if you have someone who is overdosed on oxycodone, for instance, and you give them a full blast dose of Narcan, they're going to sit bolt upright. They're probably going to start vomiting because their GI tract is totally waking up all at the same time. Probably will defecate, and they're going to be very mad at you for reversing all of those opioids because they're in withdrawal now, basically. But they're also breathing, so that's going to be kind of the trade-off there. So ideally, though, what you're going to find is if you can give smaller doses and titrate them up gradually, you can get to the point where they may be still asleep, but they're breathing at least. That's the ideal thing because a lot of these patients, I don't necessarily need to be awake. I just need them to be breathing, right? Obviously, if they're in a state where they've been perhaps not breathing for a period of time, maybe EMS is arriving and they find a patient down unknown period of time, yeah, full blast, give it to them, see if it's going to wake them up because you have no idea how long they've been apneic for. There's been a large push in Florida, especially to make sure that we have more access to Narcan. So you're going to find that a lot of police officers now carry it, EMS carries it, and it's easier now for people who may have family members who may be requiring this in order to get access to it. So it's kind of a good thing because it's like having an EpiPen, right, for patients who have history of some of these substance use disorders. And again, if you are overdosing on opioids yourself, you're not going to be able to give this to yourself because you're going to be basically unconscious. So it has to be someone else that can administer this to the patient. Joshua was saying, on the road, we always gave just enough to get them awake and breathing and try to avoid the excess vomit. Yeah, exactly. I remember one time we were on rounds in the ER and the environmental services people had just left one of the bays in the ER doing a total cleanup. And the attending was asking the resident, he said, well, what happened here? And the resident said, well, I gave some Narcan and I didn't really get the desired effect I was looking for. So I went ahead and gave it another dose. And basically caused a code brown because again the patient whole GI tract woke up at the same time and caused them to basically defecate, and of course it's a big open air sort of ER with paper curtains separating everyone, so it's kind of a bad deal. So ideally, if you can try to give them small doses, try to get them to the point where they start yawning. Usually yawning is a good sign that they are starting to wake up their brain stem there, because again it's not a lack of oxygen that they're not responding to, it's they're not responding to that buildup of CO2. Once they start to get a little bit of Narcan in and they start to respond, that brainstem detects the high levels of CO2, they're going to start to breathe again, they start to yawn, and that's a pretty good sign. Again, if they can be asleep and breathing, that's the ideal situation, right? Your nurses will thank you. Anyway, so we do have a few agents, and this can be utilized for constipation because these few agents don't cross the blood-brain barrier. So they deal with the GI effects of opioids, but they don't get into the CNS and induce withdrawal from that from there. So we have a few here called alvimapine, methylnaltrexone, and nalexagol. So you may see this for post-operative opioid-induced constipation. That's the primary place you're going to see that. And again, the benefit is it does not induce withdrawal from the central nervous system effects, doesn't reverse the analgesic effects, only affects the GI tract, which is beneficial in some cases. So if you have people who that mush and push sort of regimen was not working for them, then you could maybe utilize something like that. Okay. Anyway, so let's look at a few adjuvant and other medications we can utilize for pain here. So as I mentioned, there's different sources for pain. Actually, question here. Someone said, how long does naloxone last before they go back to overdose state? That can depend on the opioid that they have taken. So for instance, it's not uncommon for someone who's on an extended release product or methadone or something like that to have resedation. Narcan works generally about 20-30 minutes or so. It comes on really quick, but also comes off relatively quick. So that's why sometimes we have to do continuous infusions of Narcan in order to keep patients breathing until the opioid kind of wears itself out of the system. So just kind of depends. Good question. All right. So some other things we can look at. So In terms of neuropathic pain, because the pathogenesis of that is different than somatic or visceral pain, we're going to see that the treatment for that is going to be different as well. And so some of these we have not talked about. We're going to get into them in like the neurology section and the behavioral health section. But just to give you some ideas, that in order to help kind of decrease pain sensation of those nerves, we can do things to try to help decrease the number of action potentials that they're sending those painful signals. That's where we can get into things like anticonvulsants, some of our local anesthetics like lidocaine, and also tricyclic antidepressants. Again, I'll get into much more detail on these later on, but just know these are some options we have for neuropathic pain. So someone who has, for instance, fibromyalgia or multiple sclerosis or something like that, even if they don't have a seizure history, but you saw a seizure med on their profile, it could be related to that neuropathic pain that they're experiencing. And again, anything other than opioids is going to be an ideal drug because, again, of the side effects and tolerance and addiction potential and all that stuff. So again, don't go to opioids for everything, especially if it's neuropathic in nature, because it may not be the best option for those patients. Doesn't mention antidepressants, antiepileptics, local anesthetics like lidocaine, but there are others as well, right? It really just depends on what the patient's experiencing, and some of these I'll get into a little bit later on. But for instance, like muscle relaxants, why is a patient having pain? Well, some of it could be related to the spasticity they have in the muscles. So could we give something to try to relax them? That could be something like a cyclobenzaprine or Flexeril and things like that. Capsaicin is an interesting one. I'm not sure if I go into all details. Actually, I do talk about these in more detail, so I'll get into those going into it. Botulinum toxin, all kinds of things we can get into, as I'll talk about here. Someone said, Narcan can't or can induce withdrawal. Narcan does induce withdrawal. Slide says can, but also says no. So if you go back to that slide, so these are the peripherally acting ones. These are ones you would not use for opioid reversal. This would just be for the constipation. Naloxone itself does cross the blood-brain barrier and does induce withdrawal if you give too much of it. If you give small doses, then it does not induce withdrawal. But if you give if you give a full 4 milligrams or something to a patient who is chronically on morphine, for instance, then yeah, that can certainly induce withdrawal. So if I was not clear on that, I apologize. So talking about antiepileptics, here's a few here where we can, again, I'm going to talk about these in a later section here, but things like carbamazepine, gabapentin, lamotrigine can all be utilized here. A lot of these are all sedating. And again, it makes sense because they're trying to help treat seizures by decreasing hyperexcitability of neurons in the brain. It can do the same thing to these patients too. So a lot of times you can see kind of like dizziness and sedation. So again, starting low and going slow, and sometimes these may take months to really kind of kick in and get full effect, but you can at least do that and try to help kind of limit the sedating sort of effects by going small doses and gently titrating up on that as time goes on. That can help to mitigate some of those issues there. As I mentioned, tricyclic antidepressants can be used. This includes things like amitriptyline and doxepin and things like that. These basically block the reuptake of norepinephrine, meaning more norepinephrine is going to be in the synapse and is able to interact with those painful nerves. And this helps actually modulate pain a little bit. And so for a long time, these are sort of considered to be the gold standard for neuropathic pain. There are some side effects associated with them, things like anticholinergic effects and weight gain and whatnot. Again, I'll talk about this extensively in the behavioral health section coming up, but you'll still see these used all the time for neuropathic pain. So diabetic neuropathies, MS, all those sorts of conditions there. Local anesthetics are also pretty helpful, and we'll see this a lot, especially like in the surgical realm or for like post-operative pain management in terms of like epidurals and nerve blocks and things like that, because these can be opioid sparing. But basically, if you imagine a nerve transmission of an action potential, that's going to sit there and travel up the nerve and into, say, the spinal column, for instance. That happens through these nodes of Ranvier here. If you can block that by blocking sodium channels, you can block that action potential, and that's how it causes basically the numbness that you experience when you have a local anesthetic, say on the fingers or something like that. So very handy from a post-operative standpoint, because instead of giving opioid to treat the pain being caused by those painful fibers, what if I just like numbed them up and deadened them so that way the pain signals never made it to the brain? So you're going to see that used a lot in the surgical settings. So things like ropivacaine, bupivacaine have been used. Although lidocaine is probably the most common one people have heard of. And so you'll see this like with lidoderm patches. So people will do that, especially for like herpetic neuralgias whatnot. We also use some, for instance, like Imlacream, which contains lidocaine and prilocaine. We mix those two together and you can apply it to the skin, and that actually helps out with like needle stick analgesia. So if you had someone getting an IV placed, you put that on there to numb up the skin to allow for relatively painless needle insertion, which may be useful for some patients. Someone has another question. Can naltrexone be used for opioid addiction since it can be given orally in comparison to naloxone that is not given orally? Yeah, so naltrexone, I didn't mention too much here, but you will sometimes see this being used for patients who are being treated for opioid addiction. Basically, naltrexone is an orally bioavailable opioid antagonist. So naloxone does not get absorbed orally, but naltrexone is. And so what you see with that is that this would be for patients who are not actively having withdrawals, because this could induce that, but basically they would be on it 24/7. So that way, if they did fall off the wagon and go back and utilize an opioid, its effects would be blocked basically. So they wouldn't get the same high that they were looking for potentially. So could be useful, but you're going to find that from a efficacy standpoint, from a compliance standpoint, you may have some troubles there, right? Because patients may not want to take it, because if they do want to have a relapse and go back to their opioid of whatever they used, then they're not going to want to take that. So that can be a challenge, but that's again why you would see naltrexone being used occasionally. I see much more buprenorphine nowadays than naltrexone for sure. Okay. As I mentioned, the skeletal muscle relaxants, these basically work on GABA B receptors to sort of help chill out those neurons that are maybe causing that spasticity. Because again, they can develop what we call this like pain spasm pain cycle, where if you're experiencing pain in a certain limb, for instance, you're going to want to retract that limb as just a natural reflex, and that spasm can cause further pain, right? Depending on what the injury is. By interrupting this, this helps to kind of interrupt the cycle and help to decrease pain overall. And so here's a couple agents we have here, like baclofen, cyclobenzaprine, metaxalone, methocarbamol, and tizanidine. These are all pretty common muscle relaxants. Keep in mind, though, that they all cause a significant amount of sedation. So if you're adding this on top of opioids, again, that synergism is going to be present, and you could really oversedate the patient. So again, low and slow is always going to be the mantra with this stuff here. So you'll see this a lot, especially with patients who are like in rehab facilities, or if they're getting physical therapy, because this helps them to regain some of those functions by helping to improve range of motion before they start to experience pain and whatnot. So you'll see this a lot in sort of a rehab setting, which is beneficial. All right, next we have capsaicin, which most people are familiar with this as the spicy stuff in their peppers. This can be a topically applied substance you'll see used occasionally. What's kind of interesting here is that when you apply this, it actually is pretty uncomfortable. I'm sure someone has accidentally chopped up a jalapeno and then rubbed their eye right afterwards. Even though you shouldn't rub your eye, but you do it just on instinct, it seems like. It's pretty painful, and it's because it helps to release substance P, which will sensitize these fibers and cause pain to occur, right? Apologize for the screaming child in the background. So anyway, what we can do here is that by applying this chronically to the skin, you can find that you can overall deplete the amount of substance P available. And by depleting that, then there's no more substance P to sensitize those fibers. So while it's uncomfortable at first, if patients stick with it, it can be a useful adjunct in order to help decrease pain, especially with like, osteoarthritic joint or something, right? So they apply it to the knee, they have osteoarthritis, it can help to decrease pain in the long term. Unfortunately, patients don't stick with this routinely. Again, it's a topical product, it's not that most ideal dosage form, and it's uncomfortable at first, right? It feels hot initially, but if they stick with it, it does work pretty well. So compliance is a problem, but it's another available tool to you. They have to make sure that they are either putting on gloves when applying this and then removing the gloves after putting it on, or washing thoroughly with a lot of soap and water, okay? The stuff is lipophilic, so water by itself is not going to get rid of it. And if they go and touch their mucous membranes or their eyes or something like that, it's going to burn like the dickens. So make sure they're using good soap and water, or gloves would be ideal. So another alternative here we have is called tramadol. So this one is sort of a partial opioid agonist. It's pretty weak. I would consider this on par with something like a Toradol, or maybe a little bit higher up than codeine, but not on the same same levels like hydrocodone or oxycodone. So kind of wimpy, but it also has the ability to inhibit reuptake of serotonin and norepinephrine. So it is useful for if you need a little bit of opioid effect, but you also want to help out with something like neuropathic pain. This can be a beneficial thing here. It has less side effects than opioids because it's only a partial mu receptor agonist. And so, you'll have less respiratory depression seen with that, less sedation, but you can still see a little bit of that. As I mentioned, worse side effects here are going to be constipation, some somnolence. Keep in mind, this may not be fully reversible in naloxone because it's only a partial agonist because it has some other effects as well. So it's kind of a challenge when I see patients who have overdosed on this itself. Now, for a long time, this used to be like a go-to drug for PAs and NPs in Florida because it was a non-controlled substance for a really long time. So if you had someone who required pain management, but you were unable to write for a controlled substance because Florida's behind the times and a lot of things, and that includes helping out our advanced practitioners to have kind of the standard activities as other states. But for a long time, you guys couldn't write for controlled substances, and so this was like the go-to drug for in terms of like the strongest pain medication you guys could write for. Nowadays, though, we realize that it is there are still abuse problems with this. We do see that if people can get a hold of a full blast opioid, they'll abuse this just the same. So it got made into a C4, so it is a little bit more restrictive. However, you guys can still prescribe for it if you have your DEA license and all of that because Florida finally changed that law there. You also see a combination with acetaminophen. If you ever see Ultraset, that's what that's referring to. Okay, so let's talk about medical marijuana real briefly here. This is something that's hard to believe. It's already been 4 or 5 years now since it passed. But so medical marijuana is available in Florida. I know we talked about some synthetic THC products back in the GI section. So I'm talking about like dronabinol and nabilone. But we actually do have access to straight up medical marijuana now. And so it's kind of interesting when the law came to pass because they basically said you could use it for any of these debilitating medical conditions. And they defined several of them here. So things like cancer, epilepsy, PTSD, Crohn's disease, pretty wide range set of things here. They also put this disclaimer on the end. To other debilitating medical conditions of the same kind or class or as or comparable to those enumerated for which a physician believes that the use would likely outweigh potential risk. Basically means whatever the prescribing provider thinks it could be useful for, they can prescribe it for. So it kind of leaves it open so that way, even if you don't have one of these conditions, someone could potentially still get access to medical marijuana. Now, of course, you guys will not be able to prescribe this. This is only going to be for physicians who have special licensure to do so. But it is something you may find that your patients are on that you would like to know about because it could have interactions with other things that you may be writing for them, right? Or cannabis itself is a pretty interesting little plant. It has a lot of compounds, probably thousands of different compounds that you can run into. But the main ones we talk about frequently are delta 9 tetrahydrocannabinol, which is THC. That's the main psychoactive compound. If you think about someone getting high from smoking marijuana, this is what they're talking about, the THC component, okay? We also have cannabidiol, or CBD, which I'm sure most of you have probably heard of, companies getting into producing CBD products and whatnot. This is going to be useful for a lot of like the anxiety effects, the use for seizure management, things like that. That's where CBD really comes into play. But there's going to be a gazillion different types of compounds here. Cannabinol, just for instance, but there's many others. Basically, what we have in our brains are called cannabinoid receptors. There's CB1 and CB2 are the primary ones. CB1 is the main one we're going to talk about because this is going to be useful for the CNS purposes. CB2 you can find more out in the peripheral tissues. But there's a lot of really complex activity in terms of what it's going to be doing to our CNS and different neurotransmitters and whatnot. Now, what are some risks associated with medical marijuana? I'm not going to sit here and tell you, oh, well, don't use this stuff. It's not real. You got to utilize just prescription drugs. Because for some people, this is going to be an ideal thing. Either they would prefer to use something that is, say, more natural, quote unquote. Cyanide also occurs naturally in nature as well, but I don't see people taking a lot of that for good purposes. But regardless, there are some certain benefits you can get from medical marijuana here, but it's important to know the risks, right? So what it comes down to is, again, you can see issues of CNS depression. You can see short-term memory impairment, right? Motor and coordination, all of that. And again, don't let them go driving, right? They're going to be under the influence, just like they would be if they were taking an opioid for the first time, if they're taking too strong an antihistamine. I mean, any of these drugs can impair their ability to drive and operate heavy machinery, so I really recommend against doing that. I think I forgot to lock my door, so my toddler just walked in. We'll see if she pops up on the thing here. There she is. Anyway, sorry about that. I forgot to lock the door, but it is what it is. Anyway, so there are going to be some issues you can find with patients that have a bad response to marijuana, where they can have things like paranoid ideations, they can have some psychotic symptoms. This is pretty rare though, and it would just be on a patient by patient basis there. Chronically though, we don't really know the full extent of what could happen in terms of, yeah, she's pretty cute, kind of a pain in the booty sometimes, but regardless, we don't really have the full studies to know what the chronic effects are going to be here, because again, it's been very difficult to do studies with marijuana because it's been a Schedule 1 substance federally for forever basically. However, do note that this can exacerbate things like anxiety, depression, psychotic illness. So you do want to be really cautious for patients to have a history of psych stuff, because this could exacerbate it. So just be aware of that. Okay. Also, be aware of the dosage form that they're using here. So smoking, and so again, I got to make the distinction between like vaping and smoking. Smoking is actually you're lighting the product on fire and inhaling the really hot gases. That can be a problem from a pulmonary standpoint, because that hot gas is going to not be really good on all those nice epithelial cells in your respiratory tract, just like smoking cigarettes can be bad from that standpoint. So you can see things like bronchitis, you can see pneumonias develop here. What is probably better is if they can have some sort of oral dosage form, handy, or if they can have some kind of like vaping device. Usually the gases are not quite as hot there, and so that can be one way to utilize the product without having to worry about as many of the pulmonary issues. But you can still have people with reactive airway disease that can have issues associated with that. It just depends, again, on the patients. A lot of those vaping products, we don't really know what the long-term effects of all the other kind of adjuvants are in there. So sometimes they'll include things like polyethylene glycol and or propylene glycol, all kinds of different things you may find some issues with. And then there may be some small risk, let's say with like MI, stroke, and peripheral vascular disease. So again, there are risks associated with it, although it's pretty well tolerated by most patients there, right? So overall, what I'm going to say in terms of medical marijuana is, if you look at the data, there's nothing where it's an absolute slam dunk to say, yeah, this is the first line therapy for this disease state, okay? However, basically what the medical consensus is that if a patient either really thinks it might benefit them, they want to try it, it's reasonable, or if they've tried normal medical products and they have not worked for them, this may be a useful alternative, okay? So again, it just depends on the patient, what their kind of predilections are, and then if the provider thinks it could provide benefit, then they can try it out. Okay. So anyway, so overall, we're going to find that pain management is tough. It'd be easy if we had a one-size-fits-all management for everyone, but that's simply not the case there. Biggest thing is it has to be individualized for the individual patient, right? And you guys can really provide a good role by educating them appropriately to let them know, hey, what are the reasonable expectations? What are the side effects they should expect to see? What are worrisome things they should come back and talk to you about? And guide which agents you're selecting, how you titrate those things, maybe converting from one drug to another, things like that, and then helping them to really kind of manage their adverse effects. So anyway, that's the pain management section. I still have about 20 minutes here, so I think I'm going to want to get started here on the next section. But if you have any questions, let me know. I apologize about the interruption. I should have locked my door, but I forgot. Called the COVID vaccine haze. Okay, so getting into rheumatology, I'll see whatever I can touch on here. Let's talk about the immune response first. We'll probably get the background done before we have to break for the day. Anyway, what we're going to find is that with a typical immune response, which I'm experiencing right now, as it turns out, right? Handy segue, is that your body's responding to some sort of like foreign or some sort of antigenic sort of substance here. Typically this is good if it's like a bacteria or a virus or something. However, it can be bad if it's going to be yourself that you're responding to. There you go. It's always good to have students who can commiserate a little bit with having kids, and I really give you guys a lot of respect for having kids and going through PA school. I could not imagine having to do that. I was barely able to be responsible for myself in pharmacy school. So to be responsible for yourself in this very rigorous program and having little ones is a challenge. So hopefully your partner is a big help. But anyway, so what you're going to find though is that having this kind of chronic inflammation is going to lead to overall tissue destruction and damage over the long term. And so this is where also we're going to get the source for a lot of autoimmune conditions like rheumatoid arthritis, lupus, things like that. And so again, our main goal for a lot of these conditions is to try to tamp that immune system, try to chill it out, try to make sure that it's not going to be causing overall damage in the long term. And so what we can see from this inflammation is that you're going to have these leukocytes that are releasing all these lysosomal enzymes. You're going to find that arachidonic acid is going to be playing a big role here, which is a good segue from when we were talking about COX inhibition before. So you're going to see that's going to be drawing in all sorts of like macrophages and things. And overall, you're going to be getting these neutrophils coming in that are leading to all this production of our free radicals, right? All these oxidative species here that are being generated that can then just perpetuate the inflammatory cycle even further. So it's really kind of a sick cycle here where it kind of perpetuates itself and causes overall long-term damage and over a long period of time, right? And you can see here, we've covered this pathway before, but the production of arachidonic acid, having cyclooxygenase, producing all these different things here. I'm not going to quiz you on each and every single one of these, but you can see how all of these are working in concert to help perpetuate more and more of this inflammation and tissue destruction. And our goal is going to be to try to inhibit this where we can to try to interrupt the cycle. You can see here our steroids are going to come into play, COX inhibitors are going to come into play. We're going to get into all the different agents that can help us out with that. Someone says, let's see. Are there any drug interactions from medical marijuana we should know of or contraindications? I would say the biggest interactions would just be more of a pharmacodynamic standpoint. So if they're going to be on other CNS depressing medications, then that could be, again, synergistic. So if they were on skeletal muscle relaxants and opioids and a benzo or something like that, in conjunction with medical marijuana, it can help to worsen that sedation. That would at least be cognizant of that. No specific contraindications. I would just be more worried about the dosage form that they're using in conjunction with things like the history like respiratory disease. I would not want them actually like lighting up a joint or something and inhaling that hot gas because that can be problematic. They like reactive airway disease or something. So I would be cautious with that. But those are kind of the main things I would recommend. Okay. So let's talk about rheumatoid arthritis. First, again, this is going to be, again, an autoimmune condition where basically you get this symmetrical joint involvement, you get some of these extra articular manifestations we'll see as well. And basically it's causing this sort of like progressive, irreversible joint damage over time. Joint damage, not a thing, but joint damage over time with this inflammation is basically kind of chronically occurring at the synovial lining here. And so we're going to see that overall you're going to get destruction of the joint. All of this inflamed cartilage and tissue is going to eventually be cleared away by some of your immune cells. And again, the body can't tell itself from something foreign, so it's just attacking itself. We're going to find some ways we can try to interrupt that by introducing medications that can tamp down the immune system here. Now, I'm not going to sit here and talk all day about the pathophysiology, but we're going to see here that there's a lot of cells that are involved, T cells, B cells. These are going to be targets for our medications we're going to get into later, as we'll see here. We're going to try to find ways that we can try to mitigate the activity, the activation of these cells, production of these cells. These are things we're trying to do so that way we can get less of these inflammatory cytokines being made, less of these free radicals being formed, and all of that. And basically what you're going to see with a lot of our therapies, we can't necessarily reverse what is happening to the patient. We can't say take that joint that's been someone that has rheumatoid arthritis for 20 years and reverse that joint back to where it was at the baseline, but we can try to slow it down or stop the progression, and that's going to be our main goal, which is why early therapy is going to be really important here, right? Other things, TNF and interleukins are going to be really important for some of our antibodies that we're going to look at later on. We'll have some monoclonal antibodies that are able to directly inhibit these cytokines to help interrupt the immune system. And we'll find some CD receptors as well, can be really important. Note as well, we have histamine and prostaglandins being formed here. So you can already start to see some of our targets for drug therapy to try to help decrease this inflammation. So just to kind of give you a little bit of background and some idea of why we're choosing the drugs that we are, right? And you can see what it would look like if you had an actual joint would look like with rheumatoid arthritis, where you can see the eventual damage being done here to the cartilage and the synovial lining, and all the different inflammatory cytokines, all the different cells that are all being involved here. So we're going to find ways we can interrupt this with our medications. Now, I want to bring up osteoarthritis just to compare the two, because obviously osteoarthritis is not really a condition that is autoimmune in nature. This is more just like normal wear and tear done to the joints over time. And so I want to compare and contrast the two, so that way you can see like why therapy for the two is pretty different from one another. Again, this is typically seen in older patients, especially those that have like obesity, if they've had some sort of occupation or injury that has led to this. And again, this is where you're going to see a lot of disability come from, a lot of pain associated with this. This is a chronic or a common reason for patients to go on chronic opioids, even though it's probably not the best therapy for them. Just frequently you're going to find that really just replacing the joints is going to be the best thing overall. But, you know, sometimes that can be prohibitively expensive in some cases, or not feasible based on concomitant conditions and things like that. Just to compare what the joints would look like versus a normal joint, looking at osteoarthritis, again, while there could be inflammation happening here, it's not really the ultimate cause for the condition. It's just you're wearing down that synovial lining over time, either because they're chronically overweight or they've overused the joint due to work or something. Versus here, with rheumatoid arthritis, it's swollen, it's inflamed. Again, that inflammatory response was causing the damage. We're going to try to find ways to sort of arrest that. And again, over here for the, osteoarthritis, we're not going to be able to necessarily restore that joint back to normal, but hopefully we can do things, and again, non-pharmacologically try to do things to help them out. But you'll see that there's mainly just going to be symptom management here, versus with rheumatoid arthritis, we're going to focus on modifying the disease itself to slow down progression. So, as I mentioned with osteoarthritis, again, this is chronic injury, stress done to the joint over time. You can eventually see that cartilage synthesis is going to be diminished due to the fact that chondrocytes are going to be sort of coming out in diminished numbers. There's going to be more apoptosis of those chondrocytes and whatnot. And again, that inflammatory response is more of a physical sort of thing. There's more of like that bone-on-bone sort of activity causing inflammation, as opposed to the immune system coming and reacting to it because it views it as a foreign invader, so to speak. And pain is mainly going to be coming as a result of these nerve endings being activated due to mechanical, in some cases, chemical irritants. So what you can see here is a normal joint versus one with osteoarthritis. Here you can see just overall damage done, wear and tear done to the joint over time. Again, some people are causing more wear and tear quicker than others, and we'll look at some means of how that actually happens. Anyway, so our goal, these patients are actually going to look pretty similar. So we're going to see for both rheumatoid arthritis and osteoarthritis, you want to relieve pain and stiffness. You want to help to improve their function, improve quality of life, obviously, and slow down joint damage as best we can. But for RA, we're going to see that if we can actually have a chance to get these patients into remission in some cases, and then slow down disease progression. This is going to be huge for these patients because, again, we can't necessarily just replace those joints because they're going to have the same problem even if you did that. So we need to slow down the disease as best we can. That's where our medications come into play. So from a non-pharmacologic standpoint, this is huge for a lot of these patients. Although, telling patients, hey, you need physical therapy, and occupational therapy, it's hard work, right? And it's painful for them. So it's difficult to keep them compliant with this, even though it's probably one of the best things you can do for these patients here. Weight loss is hard. So a lot of people may not be able to do that necessarily for a variety of reasons. So it's easy to sit there and say, okay, let's just rely on the medications, but frequently you're going to find that you're not going to get nearly as much benefit from the meds as you would from some of these non-pharmacologic therapies as well. So that's why I always try to harp on these to say, yeah, make sure you're trying to incorporate this, even if the patient doesn't necessarily want to do it. Again, you got to have that conversation. That's part of being a provider, is being able to be persuasive, right? And kind of let them know, like, here's why this is so important. Here's why you need to try to stick with this and try to convince them. Obviously, surgery is going to be important in some cases, more so for osteoarthritis than rheumatoid. Now, this is a kind of starting off the pharmacologic therapy to sort of compare and contrast the medications we're going to be utilizing here. As you'll notice, for chronic treatment, especially for sort of the kind of chronic pain symptoms they're going to be experiencing, as NSAIDs, low-dose corticosteroids are going to be more important here. And this makes sense based on the inflammatory nature of the condition that we just looked at. On the other hand, though, for osteoarthritis, notice that there's really no role to play necessarily for corticosteroids from a systemic standpoint. NSAIDs can be useful. Acetaminophen can be useful, but notice here, acetaminophen doesn't have a whole lot of anti-inflammatory properties. So whereas with OA, you could get away with using some Tylenol for some pain relief, it's not really going to do anything for RA because all of the issue is the inflammation in the joint itself. We're going to find for acute exacerbations, anti-inflammatories are the way to go. So just like we'll see with treatment for things like MS, for instance, we need to decrease the inflammation. Corticosteroids are kind of gold standard for that. On the other hand, for OA, you're going to see that there's not really anything we can do necessarily because, again, it's that mechanical problem there. So we could utilize opioid analgesics, but we already know that's not going to be ideal for a lot of those patients there. That's why surgery is so important. And then finally, we're going to see for DMARDs, this stands for disease-modifying anti-rheumatic drugs. These are going to be sort of our hallmark here. This is the things we're going to be utilizing to slow down progression, halt progression if we can, what these patients might be on for sort of, lifelong therapy in some cases there. And then for knee effusions that happen, there'd be some cases where you do aspiration, and then we'll talk about corticosteroid injections a little bit too. Actually, I had a case, condition called juvenile rheumatoid arthritis, and actually was in the ER one time, and we had a rheumatologist come down for this kid, and this kid's knee was just like, it looked like a balloon that was blown up. It was so swollen that we came down, the rheumatologist came down, we're going to do a corticosteroid injection after aspirating out. And I think this kid ended up pulling out I think it must have been like 180 cc's of fluid off this kid's knee. And it was crazy how much fluid had just built up there due to all this inflammation and all these inflammatory cytokines just causing all this vascular leakage. I'll tell you what, the kid felt a lot better just getting all that fluid off of that knee and off of that joint. And then the corticosteroid, we'll talk about how that follows up and helps out with that. So as I mentioned, with DMARDs, it stands for disease-modifying anti-rheumatic drugs. When we talk about these, we'll mention a few types. So there's going to be the biologic and non-biologic. Biologic, as you might imagine, are going to be like your monoclonal antibodies. These are going to be protein-based products we've engineered to administer to these patients. And then we'll find the non-biologics, which are going to be like your typical routines or like pharmacologic medications you can take orally. We'll get into those in a little bit later. It'll be important to make that distinction because we're going to see that adverse effects that can happen with the biologics will be pretty different than the non-biologics, and we'll look at some compare and contrast those as we go along. As I mentioned, this is the cornerstone of therapy, so these need to be initiated as early as possible because this will slow down, hopefully halt progression to disease, and will have the most sort of favorable outcomes there, okay? But for immediate care, immediate symptomatic relief, this is where NSAIDs and corticosteroids come into play. Now, keep in mind, ideally, you want these patients to be on no corticosteroids. However, that's not really going to be feasible for many of them because of just how inflamed they happen to be. So we're going to see with corticosteroids, low a dose as possible for as short a time as possible is going to be ideal for these patients just due to all the side effects we're going to see associated with them, as we know. Anyway, so I think I'm going to go ahead and cut it here. I don't really have enough time to get into the individual drugs themselves. Do you guys have any questions before I let you go for the weekend? Hopefully this is an informative discussion and my children did not cause too big of a disturbance for you all. Yeah, so what does our syllabus say? Let me look. You guys don't want a quiz that covers stuff we haven't gone over yet? Is that a problem? Problem is I talk too long on this stuff. Yeah, it's going to cover, actually, let's just say it now, it's going to cover Unit 1. I haven't really covered any medications here specifically, so the quiz next week, that'll be the first, 25 minutes or so of class, and then we'll start with the lecture at 8:30. Hope you guys can all join me by then. It'll be through Canvas. You'll need your webcam, because it's going to be through the lockdown browser, so just like we did it last semester, I believe. So you'll need that, and then... yeah, we should be good to go. So it'll be pretty brief. It'll be similar to the ones from last semester. I might have some matching. I'll have a few multiple choice questions, that sort of thing there. So if any other questions about that, let me know. But yeah, just over Unit 1, just the pain management stuff we talked about. Any other questions I can answer for y'all? Well, if nothing else, then you guys are free to go. If you do have questions for the quiz, feel free to reach out ahead of time, and I'll try to answer those best I can. And yeah, good luck. You guys should do fine. So I'll make an announcement that'll pop up probably like 5 minutes before the quiz that will have the password and all of that. So it'll be pretty straightforward. Just over Unit 1. Hey, you guys have a great weekend. I will see you all next time.